I'm Shannon, and this will be in English, and I will be presenting on my the Master on Perceptions on Access to Health Services of Migrants with Chronic Disease in Barcelona, Catalonia, Spain, a qualitative study. This is the index of what I will be speaking about today. So to start off with, Spain has a national health system, to provide a little bit of background, which means that there's universal coverage supported by taxes and free upon delivery. Access to those without a residence permit was originally granted in the system in 2003, but then because of the economic crisis of 2012, it was rescinded, just to be reinstated again in 2018. There aren't too many studies on what access was like for this population in Barcelona, but the studies that do exist show that there were barriers for this population even after 2003, and that they worsened in 2012. Then, as we know, COVID-19, there was a greater impact on more vulnerable populations such as migrants and such as those with chronic disease. And chronic disease treatment was often postponed during the pandemic. So first, when I talk about barriers, I want to explain what I mean and how we analyze that. And we use the theoretical framework of Adai and Anderson. And we focus specifically on this tier in the middle here, characteristics of the health delivery system and characteristics of the population. And this tier focuses on potential access and the factors that influence it. The bottom tier focuses on actual access, which is utilization and satisfaction. But we looked at health system and population factors in analyzing barriers. So according to this framework, the barriers that were previously identified for immigrants in Barcelona pertaining to the system was obtaining the health card, the IHC, which one needs to enter the Catalan health system, as well as weekday clinic hours. There not being enough hours considering precarious labor conditions. For the population, evidence shows there were language and cultural differences, as well as perceived discrimination and a worsening of the socioeconomic condition of the migrants themselves after 2012. Barriers identified globally for immigrants during the pandemic were a lack of resources and factors relating to telemedicine. And according to the population, again, worsening socioeconomic conditions, issues of the digital divide, as well as stigma and contagion. So all of that to say is that despite legal access after 2003, barriers persisted and worsened in 2012. And since 2018, since reinstatement, there has been no other study for this population on what access to health is like today for immigrants in Barcelona, especially also considering the impact of COVID in 2020. So there's a need for more studies that explore how and why barriers exist and limit access to health when it's legally guaranteed. So our research objective was to analyze what access to healthcare and its influencing factors is like today for vulnerable migrants with chronic disease in Barcelona. So looking at methodology, we have a qualitative, exploratory, descriptive, phenomenological study. And exploratory descriptive because although there are studies that analyze factors, there's none in actuality about what the situation is like today. So that's why we said it's studying a phenomenon from a new angle. And from an ethic perspective, which means that we as the research team acknowledge that we were outside of the population, we are not part of the population, nor did we try to integrate into the population to better understand the context. The sample is a theoretical sample of vulnerable migrants with a diagnosis of chronic disease that had tried to use or had used this health system within the last 6 months. And our variability criteria was the possession or lack of a residence permit, a possession of the health card, Spanish, Catalan, or English language, in-person or virtual care, time residing in Spain, and sex or gender. The sampling method was intentional and accumulative. Intentional in that we sought out informants who fit our criteria, and accumulative until we felt that there was a saturation of information as similar themes began being repeated during the interview process. The final sample was 10 informants, and they were all contacted via nonprofits that I myself had personal connections to. Some of the characteristics, there was 8 male, 2 female. Most were Central and South American, meaning they were native Spanish speaking, with 1 each from Equatorial Guinea, Morocco, and Georgia. Half the informants were in their 60s, whereas half were under, with 1 informant being the father of a child with a chronic disease. Most had some level of secondary, technical, or university level education. Most did not have the residence permit, meaning they did not have legal right to work in the formal economy. Half had been in the country for under 10 years, about half over. About half were unemployed, had work in a regular economy. And here are some of the conditions, keeping in mind that most had multiple chronic diseases. Continuing with the methods, the data collection was semi-structured. Individual interviews using a topic guide, which was recorded and transcribed. These interviews and field notes were taken during by me. Each lasted about an hour, and informed consent was given verbally and written during the process, and the interviews were coded during transcription. We also approved the protocol and topic guide with the ethics committee. The analysis was a thematic content analysis using the Diane Anderson framework, using mixed generation of categories and codified quotes to look at similar themes. And we looked at the categories again in that middle tier, if you remember the framework of the health system and the population, as well as suggestions on improvement. However, we did have an emergent theme, that of quality, which under the Diane Anderson framework is under satisfaction, and we chose to analyze it further with the Donabedian framework, looking at the technical and interpersonal aspects of quality. Speaking of quality, we ensured quality of our own study by piloting the topic guide, and also in the first interview with an informant, I was accompanied by another member of the investigative team to provide feedback. The analysis and the manuscript and everything was triangulated by the research team. We used the correct checklist as well. And when thinking about my own reflexivity of how that could or could have not impacted what was said during the interview process, I am also an immigrant here in Barcelona, albeit from a very different demographic, me being a public health student with education in qualitative studies and with professional experience with migrant populations. So our main results, looking at the health system first, were long wait times, especially in diagnostic testing, urgent and emergency care, which had the consequence of worsening health, either because of increased stress in the moment while awaiting care during a critical moment, or because of a delay in treatment. For example, one informant said, "The letter arrived and the appointment is in practically a year and a month. It's not fair waiting with this pain. If I had the resource to go to a private doctor, I would, but I don't." And these long wait times were a perceived result of the lack of or the saturation of health professionals, which potentially was cited to maybe have been aggravated by COVID, or using COVID still as the excuse is why there is such a long wait time. Another factor that emerged was issues around technology. For example, La Neva Salud is highly used nowadays to access primary care, and many informants talked about how it did not work on their mobile devices or their computers. As well as another issue, technology, was the phone not being answered at primary care clinics, so being unable to call, and that often forced one to go in person. As one informant said, "Sometimes the clinics don't pick up the phone, so I have to go in person. It would be nice to call, because at times when I can't, when everything hurts, but knowing they don't answer the phone, I go in person." Looking at the population, the factors primarily had to deal with the complex relationship between one's administrative status, which then affected their labor conditions, which also conversely affected their health, and so this triangulation of issues. For one, the economic burden of associated costs of paying for their medication, paying for transportation to and from clinics, especially during nights and weekends if they had to pay a taxi, etc. If they were physically able to work, they could only mostly work in the informal economy, which meant work precarity, further economic burdens, etc. And if unable to work, informants cited their health as the reason, being physically unable, or because they had to prioritize their health. For example, the Metro card that I could afford was one of 10 trips, which I used quickly going to and coming from the hospital. When I didn't have any trips left, I walked back, which was far for not having the Metro card. And we have not had the fortune that both parents work at the same time, because one of us always has to take care of the child. In many occasions, one must prioritize health, and that means turning down labor opportunities. The other factor that kind of played into this balance was obtaining the health card, especially with the process of empadronamiento, of registering one's address with the city hall. Almost all informants spoke of the difficulty they had in finding a landlord willing to rent out a flat or a room to a migrant who does not have a legal residence permit or a legal job and who has a chronic condition. And so not even being able to have that process to then apply for the card within the health system was a barrier. Also looking at population, knowledge and technology were barriers. Knowledge of the system, of how it worked, especially upon arrival, of not knowing how to navigate everything. and issues with digital literacy of even if Maneva Salud did work on their phone, they might not know how to use it. And all of these have those consequences of, again, worsened health, as I said before, fewer job opportunities, which meant more economic instability, which meant worse health. So this cycle that keeps happening. However, the biggest facilitator in all of that were the social networks, i.e. friends and family, as well as community services such as nonprofits, in assisting with associated costs, navigating the system, and the process of empadronamiento. Example, the Red Cross helps me with my medicine because right now I don't have any money. And the emergent topic of quality, as we said, or as I said, looking at technical, structure, and process, most reported fairly positively on the technical aspects, such as knowledgeable medical staff, sufficient amount of resources, flexibility scheduling appointments, the system is integrated between the different levels of primary and specialized care. However, there was some talk on discrepancy in opinions and diagnoses, which might have resulted in a lack or delay in treatment, as well as an interruption of treatment because of change or lack of personnel, as well as being denied treatment outright for not yet having the health card. Interpersonal quality, some informants spoke of fair treatment while others spoke of discrimination. For example, in this quote, "It's not the health system, it's the workers. They look at you badly. They need to humanize the workers more. They think that one comes to take away their pension and cheat the system, but we're good people who for difficult reasons had to leave. I don't know if the Catalan is full of heart, but they treat you badly and it worsens your health." So in our grand conclusion, this is our first study, or this is the first study since the pandemic and since 2018 to analyze access for migrants, especially considering chronic disease in Barcelona, and it shows that previously identified barriers continue to exist and also illustrates barriers previously not explored. For example, in the health system, some of the persistent barriers were the long wait times that were identified prior to 2018, again potentially because of the lack of saturation of health personnel. However, some distinctions were factors related to technology, which was not as widely as explored before the pandemic. And also a grand distinction was the reported flexibility during the work week to attend primary care clinic appointments because of the work precarity, whereas in other studies it was the opposite. Because of the work precarity during the week, they didn't attend appointments. And there's more focus on this study in critical care during nights and weekends, so they didn't have to always go to the emergency care. According to the population, persistent barriers was the economic burden of costs, for example, medicine. However, distinction in prior studies, transportation focused more on rural to urban movement, whereas everyone in this study, all the informants lived within the city and still spoke of the difficulty of paying for transportation. Another persistent barrier is obtaining the health card. However, in prior studies, it focused more on the process once it's within the health system, whereas informants in this study focused on the process that comes before entering the health system, which is finding the landlord for the empadronamiento. Other distinctions from prior evidence was prioritizing health over work, as I kind of mentioned before, and this could potentially be because it is a chronic condition, it's not an acute case. Again, factors related to digital literacy and cultural barriers, which I will talk about a little bit more in a bit, is that prior studies included more non-native Spanish speakers than this study. Conclusions on quality is there is one study on quality for immigrants in Barcelona prior to 2018, and since that study, this reported a positive improvement on the technical aspects. However, there was still a lot of talk about discrimination that was also reported previously. Going back to what I meant about the non-native Spanish speakers, we do recognize that could have been a limitation of the study. It was very difficult to find speakers and informants from other cultural backgrounds, such as Pakistani, Filipino, Maghreb. We felt that was mostly because of aversion to the study, especially even when the documents were translated, the informed consent was translated, and the guide was translated, there was still a lot of aversion to signing paperwork. And just informant availability in general of coming into an office to do an hour-long interview. Because of the time constraints, we were unable to triangulate the results with the informants, but we do plan on presenting these results to the participating institutions in the future. And even though my personal connections with some of the informants and the institutions themselves facilitated contact, it also means that all of our informants came from within a network of aid, so we are not capturing informants that might not have that help from nonprofits to pay for associated costs. So in conclusion, if a universal health system is to be truly accessible to all, it must consider how social determinants and system factors either hinder or facilitate access, especially for the most vulnerable. And I was involved in every step of the process, from the literature review, to the protocol, to the field work, to the analysis, to this defense. And this was the bibliography that I used. Thank you.
Okay, just in time.
Sí.